Dear Chair, dear committee, my name is Patrik Kreuter, and I'd like to introduce my PhD thesis topic, the latest advancements in digital orthodontics. I'm a first-year resident at the Department of Pediatric Dentistry and Orthodontics. My supervisors are Noemi Rózsa and Dorottya Bányai, and my SMS is Petrana Martinekova. My mission is to contribute to the development of orthodontic guidelines, providing high-quality treatments without adverse effects or compromise. My mission and my vision is to help more people smile confidently. I have two specific goals and two ongoing projects, which are both systematic reviews and meta-analysis started this autumn. My first one is investigating the differences in root resorption between fixed appliances and aligners in permanent dentition. Fixed orthodontic appliances often cause aesthetic and hygienic difficulties during the treatment. However, aligner systems are more comfortable and aesthetic with less treatment-associated periodontal risk and improved patient satisfaction. Orthodontic treatment is one of the most common causes of external apical root resorption, and it can occur in 20 to 100% of orthodontic treatments. Aligners previously showed lower prevalence and severity in root resorption on radiographs. However, more accurate CBCT studies have been only conducted recently. Our aim is to investigate the differences in terms of root resorption between aligners and fixed appliances. Our clinical question is how do aligners perform in terms of external apical root resorption compared to fixed appliances. We use the PICO framework, where the population is patients with permanent dentition. Our intervention is aligners, and we compare it to fixed appliances. Our primary outcome is root resorption measured as a root length change on CBCD recordings, and our secondary outcome is the same measured on radiographs. Our hypothesis is that aligner therapy causes less severe root resorption compared to fixed appliances. Our clinical implication would be higher acceptance rate of treatment plan and improve patient satisfaction during the treatment with less severe external apical root resorption. We've conducted our systematic search in 4 databases on the 13th of November with the following search key. I would like to shortly introduce 3 of my key articles. The first one has the strength of comparing not only fixed appliances and aligners, but introducing both self-ligating and traditional fixed appliances, which will hopefully enable us to create subgroups for these. The groups were measured by case severity with the use of discrepancy index introduced by the American Board of Orthodontics, and also the root volumes were measured as well, so we don't have only data on linear measurements. The limitations are that only Class 2 Division 2 patients were examined, and the study design is retrospective. In our second key article, also traditional and self-ligating devices were examined, and as the population is younger here, it was important that the inclusion criteria included root apex completion, so we can compare it to the other articles. The limitations are that only Class 1 patients were examined, and as it was a pilot study, there was a low number of participants. Also, it was a retrospective study as well. In our third key article, while we don't have both traditional and self-ligating on traditional fixed appliances, and it's still a retrospective study, we have a higher number of participants, 70 to be exact, and the groups were measured again by the discrepancy index. Also here, not only maxillary teeth, but mandibulary front teeth were measured. Here you can see the flowchart of the selection. We started with roughly 7,000 articles, and now we are doing the full text selection. We successfully submitted our Prospero registry, which has been accepted. In my second project, I'm analyzing the failure rate and adverse effects with indirectly versus directly bonded orthodontic brackets. The conventional direct bonding of orthodontic brackets requires high precision, as misplacement of orthodontic brackets could cause unwanted tooth movement. Indirect bonding is more predictable and more precise and can offer decreased chair time. Several articles show controversy regarding the differences of the two modalities in terms of bond failure, plaque accumulation, and white spot lesions. Since the latest reviews emphasize the weakness of available evidence, new studies, including RCTs, have been published. Our aim is to objectively compare the two treatment methods in terms of the aforementioned outcomes. Our clinical question is, what is the performance of indirectly versus directly bonded brackets in terms of failure and adverse effects? Here we use the PICO framework as well, where population is multi-bond appliances. Our intervention is indirect bonding compared to direct bonding. Our primary outcome is debonding, and the secondary outcome is plaque accumulation and formation of white spot lesions. Our hypothesis is that indirect bonding is non-inferior compared to direct bonding in terms of these outcomes. Our clinical implication would be less chair time at the orthodontist with similar occurrence of adverse effects. We have already started our preliminary search with the following search key in 3 databases and recognized some key articles which are still being processed. It's also important to mention that there's no ongoing review based on the Prospero registry. And as you can see, in my second topic, we are still checking the feasibility of the project, and if we find it feasible, we will proceed to the Prospero registration. Here you can see a summary of my 2 projects. As you can see, I'm planning to publish my results next year. I would like to thank you for your attention with a quote from Baruch Spinoza. The highest activity a human being can attain is learning for understanding, because to understand is to be free. Thank you for your attention.
How consistent are your key articles in your first project regarding the inclusion criteria?
Thank you for the question, and I think it's an important one. So there are several confounding factors when we investigate this topic, and thankfully all 3 key articles are quite consistent with the inclusion criteria. They are all investigating permanent dentition without the history of previous root resorption, dental trauma, or previous root canal treatment. And these inclusion criteria help us to eliminate some confounding factors, but we will still have some, for example, age and the duration of the treatment.
Exactly where do they measure the root length, and how do they measure the root length? And the second question is, you mentioned that in the second project you want to examine the plaque accumulation around the brackets. Is there any specific index for it, or are you going to use the conventional ones?
Thank you for the questions. So regarding the first one, it was an interesting and hot topic for me as well, because I found out that some key articles can be included because they use different measurements. The 3 I introduced measured from the incisal edge to the apex, so they were consistent and they had the same linear measurement. But there are studies which measure only from the cemento-enamel junction to the apex, so it's going to be difficult to include those, but hopefully in the systematic review part I can include them. And regarding the second question, I'm not aware of any scoring system for especially orthodontic patients. And based on the studies I saw, only the traditional periodontal indices are used.
Maybe external root resorption is associated with a specific type of movement rather than all orthodontic movement. So that can aligners used in all these cases to substitute the conventional, or
Thank you for the question. I think you've highlighted one of the biggest limitations when we are comparing fixed appliances to aligners. So it's important to note that with the use of aligners, we are not using the same movements. Usually the root movements are different, and that's one thing why they can be more beneficial in terms of root resorption. And it would be important to make differences between the cases, because, for example, intrusion of the maxillary front teeth, that's the most common cause, for example. But an angulation of the teeth, for example, less commonly causes root resorption. So most of the studies lack this aspect to make difference between movements, but it will be important. Thank you.
I'm interested in your background. Do you know when they usually detect this root resorption? Is it during treatment or after treatment? Do you know anything about this?
Thank you for the question. It really differs between country and country. There are different protocols. For example, here in Hungary, in our clinic, we do OPGs, so panoramic radiographs, before and after the treatment. Only if we find tooth movement or some unwanted effects, then that's the time frame when we make new radiographs so we can notice it. And that's, I think, the main reason why CBCT studies weren't available yet, because it's been introduced lately, more widely than before. So most of the times we create an OPG before the treatment to know if there's already an occurring root resorption, because that can make a difference in the treatment. But most of the cases, it's after the treatment that we realize that root resorption occurred.
You mentioned the limitation that class 1, class 2, so the different studies using different inclusion of the patient. But do you have any evidence that does it make any effect on the root resorption? Because if it doesn't matter.
Thank you for the question. So previous studies have shown that, for example, the intrusion of the teeth is the most common causes of root resorption. And while this classification may not be widely known, it means that the different tooth positions, both of the, it's a sagittal discrepancy measurement, and it measures the differences in cases in terms of molar and canine relation. And yes, it does have an effect, because, for example, in a class 2 patient, where they have either a deep bite or an open bite, and we have to extrude or intrude the teeth, that's going to make a big difference, and we will have to investigate that later if we have the chance to create a clinical trial.
Do you have any data in this article but that these teeth which has root resorption are necrotic or vital? Because that would be very interesting for us.
Thank you for the question. As most of the root resorptions are mild, these were vital teeth, but they didn't actually measure it at the end of treatment.